Ladies and gentlemen, welcome back to Gastroenterology. We're now on Chapter 7, our second to last chapter, and we're going to be talking about my favorite organ, the pancreas. That's right, the pancreas is my favorite organ. And for the usmle, for the ABIM, whether it's Step 2, Step 3, or the actual board exam, they're going to want you to know a lot about the pancreas. It's a great deal more than just simply acute pancreatitis. But let's begin with our first case. You have a 44-year-old female who presents to the hospital with epigastric pain radiating to the back associated with nausea and vomiting. Epigastric pain radiating to the back, there's only a few things that can do that. Now they're telling you there's nausea and vomiting, and the pain began suddenly 3 hours ago without fever, chills, or diarrhea. Now they tell you her blood pressure is 130/70, her pulse is 88, and her respirations are 12. On exam, they tell you she has no bowel sounds, but marked epigastric tenderness, and on lab, she has a leukocytosis of 15,500. The BUN and creatinine are normal, and the AST is elevated at 255, bilirubin's at 1.1, and then they give you a piece of advice, a piece of information that really helps you narrow in the diagnosis. They tell you that the amylase is 2,311, and in case you didn't know, that is definitely elevated. Alk-Phos is 122, which is about a smidgen higher than normal, but pretty much benign, and ALT is 244. Now right over here you see that the AST and the ALT are both equal. They tell you this because they don't want you to start thinking about 2-to-1 ratios and 1-to-2 ratios and viral and alcoholism. They want you to simply hone in on this point right there. And they want to ask you which of the following is or are true regarding the diagnosis. And so they're going to go through and they're going to say, well, is it the serum lipase needed to confirm the diagnosis? Is a CT scan needed to confirm the diagnosis? Laboratory testing alone already demonstrates pancreatitis, which we know to be the diagnosis. Or is MRCP needed to rule out a common bile duct stone? Think about this for a moment about what you know regarding diagnostic testing of pancreatitis. All that rigmarole was necessary to set up this one simple question. Do you know what the best test for pancreatitis is? The answer? That's right, choice B. A CT scan is needed to confirm the diagnosis. Now you might be wondering, well, why do we need a CT scan to confirm the diagnosis? Well, I'll tell you why you need the CT scan to confirm the diagnosis. Amylase being elevated is sensitive. Yes, we do know that hyperamylasemia will be associated with pancreatitis. However, I could smack you in your submandibular glands and cause you to have a transient elevation in your amylase as well. It's not specific. Lipase, on the other hand, is very, very specific. So when you have amylase and lipase together, you can confirm the diagnosis, but again, those are the best initial tests. The most accurate test is a CAT scan, because a CAT scan does more than just tell you, is the pancreas inflamed? It also tells you, if the pancreas is inflamed, what kind of pancreatitis? Is it hemorrhagic, necrotic, and so forth? It also allows you to Balthazar score. Now what is Balthazar scoring? Balthazar scoring tells you the severity of the pancreatitis. And based on the severity of pancreatitis, your management actually changes. Which of the following is true regarding the severity in this patient? They go through and they give you a variety of choices. The patient has mild disease. The patient has currently mild disease but must be observed closely during the first 48 hours. The patient has severe disease, or necrotizing pancreatitis is definitely not present. The answer here is choice B. The patient currently has mild disease but must be observed closely during the first 48 hours. Why is Ranson's criteria measured on time 0 and then 48 hours later? Because it's shown to be able to predict prognostic viability, meaning it prognosticated how the patients were going to do. And that's the point here. When a person comes in with actual pancreatitis, the pancreatitis itself isn't what's going to hurt them. It's the systemic sequelae. For example, third spacing and the severe hypovolemia. That's why the treatment of pancreatitis hasn't changed in 50 years. It's fluids, 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 and pain control. And more fluids. Now, what does a discoloration that's purple of the skin on the left flank of a patient who has pancreatitis indicate? Well, what that indicates, mind you, is going to be what? That's correct, a retroperitoneal hemorrhage. It indicates a retroperitoneal hemorrhage. Now, how do you remember what kinds they are? Well, if it's a Cullen's hemorrhage, it's going to be on the belly, around the umbilicus. But if they say there's flank hemorrhage, that's a Gray-Turner sign, and that's flank hemorrhage. Now I'm going to go off the screen here for a second. Okay, this is basically what a retroperitoneal bleed is. Remember, it's behind the peritoneum. And when it's behind the peritoneum, you have to keep in mind there's only a few structures there, one of them being the pancreas. Now, once you've gotten an idea of the actual anatomy, you can then realize, well, okay, if the blood was more along the sides, it's going to track down, you're going to see it on the flanks, and there's your good old gray Turner sign. Or if the blood is going to track forward, you're going to see it collect on the periumbilical region, that is your Cullen sign. Your next question is the following. If the bilirubin is elevated, when should an ERCP, known as endoscopic retrograde cholangiopancreatography, be performed? The answers are the following. If the alk phos is elevated, if the pancreatitis becomes severe, if the patient develops signs and symptoms of biliary sepsis, or if the patient develops a significant amount of pancreatic necrosis. The answer here really depends on how the patient does. The only choices here are really between C and D that are focused on the patient. The point is you cannot develop and diagnose pancreatic necrosis without another CAT scan. But you can watch and see if they develop signs and symptoms of biliary sepsis. Because remember, pancreatitis, the two most common causes are alcoholism and gallstones. So if they have gallstones and they develop pancreatitis from that, it's very possible that gallstone could be sitting at the actual ampulla. Because at the ampulla, it's going to block off both the pancreatic duct and the common bile duct, which means you're going to develop cholangitis. An ultrasound in a patient shows numerous gallstones in the gallbladder, and the biliary tree is not dilated. After 3 days, the pain resolves and amylase and LFTs return to normal. Which of the following is necessary as a recommendation for this patient? Should you A, recommend a cholecystectomy? Should you B, recommend an avoidance of alcohol for life? Should you C, MRCP? Or D, ERCP? Now, think about what's happened here. This patient has a gallbladder with gallstones in it. The bile tree is not dilated. That means the stones have probably passed. But the point here is that if you've had one gallstone cause pancreatitis or cholangitis or any itis from a gallstone, the likelihood is going to happen again. And so therefore, get that gallbladder out of there. That's right. Get it out as quickly as you can. Once the patient is ready for surgery, remove it laparoscopically. Now, they're going to give you a list of medications on the boards. Now, we know, ladies and gentlemen, that there are so many different medications that actually will cause you to have pancreatitis. There's medications here and there and everywhere that cause pancreatitis. In fact, there are so many medications that do it, the boards realize this. And they like to ask you about the prototypic ones, the ones that are very, very common in doing so. Well, now, when some of you say, well, which medication causes cancer? Well, we don't know that. Which medication causes pancreatitis? Alcohol. But alcohol is not a medication. For some, it's more of a treatment, and that's really when they're sad. And we shouldn't drink when we're sad. That's just bad, bad, very bad. So now, let's go ahead and figure out, of these listings here, azathioprine, DDI and azathioprine, or metformin, which one of these are going to cause pancreatitis? Well, choice C, DDI and azathioprine are the two that we don't really remember offhand. But can lisinopril cause it? Yes, it can. Can ACE inhibitors cause it? Yes, it can. So the point is there are a lot of medications that are going to cause pancreatitis. What you need to do is remember the most common. And the ones that are going to be most common are the ones that you've seen on practice questions. Now let's go ahead and talk about recurrent idiopathic pancreatitis. What is the most likely cause of acute idiopathic recurrent pancreatitis which of the following? Meaning, what is really the underlying cause for it? Now, that means a person has pancreatitis, and it's not from alcoholism, it's not from gallstones, it's not from a spider bite, it's not from a scorpion bite. So that means one of these 5 things is going on. Now, when someone has recurrent disease happening over and over and over and over and over, that usually means that either something's changed in their anatomy or physiology, or they've had a congenital problem. Now, we're talking about adults. If it wasn't a congenital problem, they would have been found out many, many, many years ago. Therefore, it has to be something that's physiologic or pathologic. Sphincter of Oddi dysfunction does fall into that. Microlithiasis, or biliary sludge, falls into that. Pancreatic divisum, yes, it actually does present in adulthood, but that would be congenital. Autoimmune pancreatitis, kind of hard to say. Or viral etiologies. Now, viral etiologies, someone have recurrent virus infections, that's a little strange. So, which one of these is really the most common from A through D? Well, it turns out that since gallstones are one of the most common, broken down gallstones or gravelly gallstones or microlithiasis is the next most common, meaning the next most common for idiopathic recurrent pancreatitis. So remember, when someone tells you they have sphincter of Oddi dysfunction, me myself as a possible future GI want a scope, well, I don't believe in sphincter of Oddi's dysfunction. I don't think it exists. Microlithiasis definitely exists, and therefore you choose that as the correct answer for recurrent idiopathic pancreatitis. Your next question. What is the best approach to a 38-year-old woman who has no history of pancreatitis or alcohol use and is found to have a 3.7 centimeter septated cyst in the tail of the pancreas on CT scan and endoscopic ultrasound? What are you going to do? Well, it's pretty straightforward. You have something in the pancreas. She's young and has no history of having any reason for insult to the pancreas. That means no alcohol use or pancreatitis. As soon as you have something in the cyst, as soon as you have something in the tail of the pancreas, the head of the pancreas, the body of the pancreas, you have to get it out. And therefore, distal pancreatectomy is the correct answer in this case. Now, why do they say septated cyst? Because when you have a septated cyst, that kind of throws you off a little bit. Because we all know that as soon as you have something that's a solid mass, it's got to come out. But it's also true of septated cysts. The diagnosis in this patient that we're talking about now of infected necrosis during attack of acute pancreatitis is made by which of the following? Well, how do we actually make a diagnosis of necrotic pancreatitis? Is it from the contrast-enhanced CT scan? Is it from image-guided fine needle aspirations of necrotic area fluid collections? Maybe. Early surgical explorers? Seems a little invasive. MRI or clinical deterioration? Well, listen, a lot of people deteriorate clinically before they get better. That's not a reason to think that it's going to be necrosis. The answer is you have to do image-guided fine needle aspiration. Here's why. Because it accomplishes 2 points. Number one, if they have necrotic pancreatitis, you go ahead and you find out through an image-guided fine needle aspiration that there's necrotic material or there's a fluid collection there. The other point is you can then, with that biopsy, culture it. Because if it's going to be necrotic, there's also a possibility of it being infected. And therefore, you know how to target your antimicrobial therapy if need be. Your next case is a 22-year-old woman who's thrown forward when she stops suddenly while riding her bike. She hits her abdomen against the bars of the actual bike, and the next day she presents to the ER with severe pain. She has marked abdominal tenderness, and the only thing you see is an amylase of 2,120. Which of the following is the most likely diagnosis? Is it a gastric ulcer? Ruptured viscus. Ruptured viscus. That means something broke. We don't know what. Traumatic pancreatitis or ruptured spleen? Think about it. She went forward, now she has an elevated amylase. It's got to be something obvious, right? No. The most common thing that you're going to see is going to be ruptured spleen. The most common organ to blow up on blunt trauma to the abdomen is a spleen. The reason why they gave you the amylase is, yeah, I could punch anybody in the stomach and cause their amylase to go up, but I'm not going to cause traumatic pancreatitis. That's like the Socratic method being traumatic. You don't have traumatic Socratic. There's no real traumatic pancreatitis. There will be pancreatic fracture and pancreatic duct disruption, but there's no traumatic pancreatitis. Can you imagine if that was the case? Every single boxer in the United States would have pancreatitis after every single match because he get punched in the stomach all the time. But a ruptured spleen, that'll mess you up. Now, a 55-year-old man comes in with jaundice. Oof, 55 and jaundice, that's a scary thing to have. And then they tell you there's a 2-centimeter mass in the head of the pancreas documented by MRI. Endoscopic ultrasound confirms that the lesion does not penetrate the portal vein. There are no gallstones, no common bile duct stones, there's no adenopathy, and the guy is otherwise pretty healthy. No history of alcohol use, no other medical problems. Which of the following is the most appropriate management? What they're trying to say is you've got a guy who's got a solid mass in the head of the pancreas. Ladies and gentlemen, there is a rule amongst surgeons. Now, I'm not a surgeon. I'm in internal medicine going into GI. But what I will tell you this is there is a rule amongst surgeons that is the same rule amongst all people in medicine. The minute you have something in the pancreas, no matter where it is that's solid, it comes out immediately. There's no questions, there's no ifs, there's no buts. Because I'd rather be wrong and have that thing just be nothing than it be adenocarcinoma and cause mortality. Because if you notice the description, he had no adenopathy, he had no local invasion, it's very possible this could be early pancreatic cancer. You can get it out. I have seen patients in the clinic, and I've seen cases at Lenox Hill where I actually was a resident, in which patients had T1 lesions, very, very early pancreatic cancer that was just picked up on accidental MRI or CT scan. And they were able to have a Whipple procedure, laparoscopically, no less, and be cured of pancreatic cancer. Now imagine if you could tell your patient that. Imagine if you realize that the minute you see something solid, you don't sit on that. There's no repeat imaging. There's no time to waste. You get that guy into the OR, you take that out, and you readjust his anatomy, because that's what the Whipple procedure is. A 45-year-old woman presents with abdominal pain, amylase of 3200, and AST of 150. Bilirubin is normal. Alkaline phosphatase is slightly elevated. She denies alcohol use. Ultrasound of the abdomen is normal. There are no dilated bile ducts, and her serum triglyceride is 550. Serum triglyceride is 550. Most likely cause of acute pancreatitis is which of the following? I told you about triglycerides. Now, a lot of you I know are thinking it's got to be triglyceride-induced acute pancreatitis. But that has to be over 550. More likely, it has to be over 1,000. And they told you it was only 550. So when you click hypertriglyceridemia-induced acute pancreatitis, 1,000 or greater. This is most likely a past gallstone. Because what's the most common cause? Gallstones and alcohol. An elderly alcoholic comes to you 10 days after the onset of pancreatitis with persistent fevers and a high white count. What is the most likely diagnosis? Well, 10 days later, after pancreatitis, the most common thing to occur is pancreatic necrosis. And how do you treat this? Very straightforward. Once you go ahead and you do a CT-guided biopsy, you give IV fluids and antibiotics, and that'll take care of it. An elderly alcoholic male presents 2 months after one bout of pancreatitis and has palpable abdominal fullness right here, and there's palpable cystic mass on exam. What's the diagnosis now? That's correct. This is pseudocyst. What's the treatment? Well, if it's painful, you drain it. That's it. A 34-year-old man presents for a narcotic prescription due to chronic pain, which he claims is a chronic pancreatitis. Now, this is kind of a concerning thing, right? Chronic pain, narcotic prescription, maybe he's pain-seeking. He describes an epigastric pain that is dull and radiates to the back. The pain began several years ago after a 10-year history of binge drinking. He's also had no diarrhea or weight loss with no prior hospitalizations or surgeries. He does take pancreolipase. The abdomen reveals bowel sounds that are normal and is soft but tender in the epigastrum. Other findings include a normal white count, CBC, BU, and creatinine are normal, albumin is normal, electrolytes are normal, LFTs are normal, amylase is normal. This guy says everything's normal and he's complaining of pain. I know a lot of you are thinking, call the psychiatrist. Which is the most sensitive and specific test in the diagnosis of chronic pancreatitis. Now, they didn't care if you knew if this guy was telling the truth or not. That's what the boards are so sneaky in doing. They make you think about, oh, this has got to be pain-seeking. They don't even care about that. They want to know, do you know what is the best test for chronic pancreatitis? The answer, ladies and gentlemen, it's not what you think. It's not X-ray. For you to be able to pick up calcifications in chronic pancreatitis on an X-ray, they have to be huge and very, very dense. What's a better test? Secretin stimulation testing. Now, if chronic pancreatitis does happen to be present, what is the best method of treating chronic pain in the absence of diarrhea or dilated pancreatic ducts? Remember, this is a very strange caveat. They're not telling you he has diarrhea, and they're not telling you he has dilated pancreatic ducts. They're talking simply about the pain. And what's been found to be the best is actually not giving chronic narcotics. It's not actually doing pancreatic enzyme supplementation, because that doesn't affect the pain. Antioxidants, they don't do anything. What will help is an EUS celiac axis block. What does this do? This is actually endoscopic ultrasound guided down into the stomach. They find the celiac trunk from a vascular point of view, and just above that is the celiac axis, which is an area of nerves. And what they'll do is they'll take the needle, jab it into those nerves, make sure there's no bleeding, and then they're going to inject lidocaine and straight up isopropyl alcohol. And what does that do? It basically destroys all those nerves that are connected into the pancreas, and all of a sudden, do you know what the patient does after he comes off of anesthesia? Oh, I feel so much better. Pain goes away. Because what do you need for pain to happen? Not an injury. You need a nerve to carry the impulse. But if I destroy that nerve, no more impulse. No more impulse, no more pain. And what happens? No more narcotic abuse. Therefore, the best the best treatment is EUS celiac axis block. Now, from this list of patients, which patient with pain from chronic pancreatitis would actually benefit most from actual surgery? Now, this is one where they're going to ask you not so much about the EUS celiac axis block. They want to know, all right, we're going to move away from that. Who's going to do better with surgery, not from an endoscopic procedure? Well, that would be the person who has something that can be fixed. The patient with an inflammatory mass in the head of the pancreas. Inflammatory mass, you maybe don't want to stick a needle in there anytime soon, so you want to leave it alone. Steatorrhea just means oily stools. Can't really do much with surgery there. Diabetes can be fixed with surgery. The United States would be in a lot better position. Therefore, it has to be the guy who has a congenital or slightly anatomical defect. That's always what surgery helps with, and that is the one with a dilated dorsal Santorini duct. A patient is diagnosed with pancreatitis secondary to hypertriglyceridemia. He develops, I even said it that way, he develops hypotension, renal failure, ARDS, and DIC. He's received imipenem, he's on mechanical ventilator in the ICU, but no evidence of gallstones or biliary obstruction. They go ahead and show you that thing, and they tell you the diagnosis is what? They want to know, do you know what the diagnosis is after looking at this image? And the answer there is pancreatic necrosis. You see areas of necrotic mass on the actual image. And the treatment, therefore, is what? Well, you have pancreatic necrosis in a patient who's critically ill. Obviously, you're going to do the CT-guided biopsy, you're going to start antibiotics, but because he's so sick, you're also going to consider debridement. That's right. You're going to take him to the OR and remove the necrotic tissue. Now, a lot of you are wondering, well, opening the guy up, well, you can actually even do endoscopic debridement. That's correct. Endoscopic debridement can be done through a gastrostomy. Now, what's a gastrostomy? It's basically a hole in the stomach. A young patient presents with severe nausea, vomiting, and severe epigastric pain radiating to the back for the past couple hours. Intestinal perforation and infarction are ruled out, and you think he has acute pancreatitis. Labs show an amylase of 190. What condition could falsely depress the amylase levels? What condition could falsely depress your amylase levels? This guy is not perforated, not infarcting, but he has acute pancreatitis. Something in his condition, something about him, is causing that amylase to be low. The answer? If he happens to have hypertriglyceridemia, your amylase levels will be falsely low. Same kind of thing comes out, but what falsely lowers your BNP in CHF? What falsely lowers your BNP in CHF? The answer? Obesity. Ladies and gentlemen, that is the end of my favorite, the pancreas. I'll see you back at next time when we talk about hepatitis and the liver, another area that I just love.